Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. Welcome everybody back. Today we're going to talk about chest pain in the PEDS ED. And if you work in a community or adult-based ED, chest pain is something that you're going to see all day, every day. It's something that we work up many times a shift. But chest pain in kids is certainly less common. I can't remember if I ever saw a child in the community ED that came in with a complaint of chest pain. And when I transitioned to PEDS EM from adult EM, I was really happy to leave all those ACS workups behind me. However, I quickly found out that I was going to see kids with chest pain. And chest pain scares people. I think parents are pretty quick to bring their kids to the ER when they have this complaint. But the differential diagnosis in kids is really significantly different than what we see in adults. And that was quite an adjustment for me. I learned a lot in my first few years in the PEDS ER about what we were going to look for in a kid with chest pain. So although MI and PE, two common adult differentials, is pretty low on the pediatric differential list, kids still have some high-risk diagnoses that you don't want to miss. So I'm happy you've all decided to join us because we have an amazing guest with us today, and we're going to discuss how to work up chest pain. So joining me today is Dr. Sarah Sterner. She is a pediatric emergency medicine physician and our medical director here at Children's at Erlanger. She's been an amazing mentor to me, and I chose her specifically for this podcast because truly she's taught me the most about working up chest pain in kids over the years. And y'all, people say that I am busy. This woman is one of the busiest people I have ever met in my entire life, and she is many things to many people, including our family of providers at Children's. So we are really fortunate to have her here today on the podcast. Welcome to the podcast, Sarah.
Thank you. I appreciate it. I'm happy to be here.
Well, before we dive in and talk about chest pain, tell us a little bit about you and your background.
So I am double boarded, so pediatrics first and then pediatric emergency medicine, which is the common pathway for the majority of the pediatric emergency medicine docs. I've been here in Chattanooga about 10 years working at Erlanger and have a really amazing team. I will also say that I am thrilled to be here today with you because I think this is pretty amazing what you're doing with PEM Chat. And I'm happy to actually be a big part of it. So,
yay. Well, some of the most valuable insights that I've really gleaned as an APP over the years is really listening to physicians and hearing them kind of talk through cases. It's great to have a more experienced provider and just like hearing how they think about their differentials, how they interpret the different diagnostics they order. It's been so helpful for me as I develop, how to broaden my depth in pediatric knowledge and how to work up patients. So I thought for this podcast, we could just do some scenario-based things to kind of contextualize what this is going to feel like in the ER, some of the things that you are going to commonly come upon in the PEDS ED or in a community ED rather. Okay. So before we get into actual cases, in general, Sarah, what would you say are the most common reasons kids have chest pain and come into the ED?
So really the most common reasons for chest pain in children are generally benign causes. So the two most likely things are going to be GI-related symptoms or musculoskeletal symptoms. So things like reflux and costochondritis, even gas can cause kids to be kind of doubled over complaining of chest pain if the gas is kind of up in the upper portions of the bowel. And so that we're going to see that more often than the actual truly concerning causes of chest pain. Most of the time, these kids look really well. And so I think you can get a good sense of which ones are which. But man, there are some that will surprise you, which is why we look.
So what would you say the don't miss diagnoses are in these kids with chest pain?
So the two biggest ones I think are kind of hard to diagnose are myocarditis and pericarditis. Because they can present in with such benign symptoms and with symptoms that appear to be related to so many other things. But certainly a pneumonia, especially if it's a complicated pneumonia like an empyema or an effusion, pneumothoraces, and then hypertrophic cardiomyopathy is the other big thing that we worry about, which is very rare, but we do see it. Obviously, chest trauma is a possibility, but you're going to have a good history to lead you down that pathway. And then when we think about like a PE is on the list, it's just uncommon. An MI, like I've actually never seen a STEMI and I've actually never seen an MI at all in a pediatric case. Though we look for it, that's the likelihood of finding that's very low.
And I think, experienced ED clinicians, when people hit the door, typically, order a workup, right? Even before we see the patient, we're just trying to be really efficient. Is there an approach in children for that? Is there something we can like order when they hit the door or when we see the chest pain complaint?
Wow. So hopefully you've got a complete set of vital signs already. Like that should be done in the triage process. But if you don't, those are exceedingly important. Making sure you know the pulse ox, the respiratory rate, and the heart rate specifically can really lead you down particular paths to diagnoses. So looking at those before you even put the orders in would be valuable. And then my go-tos are a chest X-ray and EKG. And those are ordered on almost all chest pain complaint patients before they get to the emergency or before I get into the room to see them.
And I bring this up because I was working out at Erlanger East years ago before I worked at Children's and had a kid with chest pain. And I ordered my usual, which was a chest x-ray, an EKG, and all the labs. So a trope and a 2-hour trope and all the things that go with that. And I remember my attending after I saw the patient said, does he have a pneumothorax? And I said, I don't think so. He has breath sounds in all 4 fields. And I'll be damned if he didn't have a pneumothorax. And I was kind of embarrassed when I had to order all the troponin and all the extra things. So, just a pearl in kids that you don't have to put that whole workup in on the front end. You can start with something more simple, the EKG chest x-ray, and kind of go from there.
Right.
Okay. Awesome. Well, unfortunately, we can't cover every single diagnosis for chest pain in the world, but we're going to kind of hit the highlights today. And let me tell you about the first case, and you can kind of walk us through how you think about it.
Okay.
So case number 1, 14-year-old male comes to the ER with chest pain. It started while he was playing basketball at school. His coach pulled him from the field because he could tell he didn't seem okay. And after sitting for a few minutes, the pain went away. His parents report this is the first time they were aware he's ever had chest pain. But when you talk to the patient more, he's like, oh, I've been having chest pain with exertion or with activity when I play ball for a little while. The patient appears well. His vital signs are all very normal, and he has no current chest pain. So what other questions would you ask this patient?
Well, so first of all, I'll tell you I'm concerned because chest pain with exercise is a red flag in pediatrics for sure. But I would want to get a little bit more into detail about the previous episodes. I would want to know whether he had shortness of breath with it. Did he have sensation of palpitations with it? Asking things like, can he lay flat at night? Like, does he have orthopnea? And then asking for signs or symptoms of extremity edema would be important because given the history, I'm really kind of going to dig into the cardiac symptoms to sort of tease that out and make sure that there's, to more deeply evaluate for potential cardiac causes.
And when you do an exam on this kid, are there any things that stand out to you as being really important not to miss?
I mean, in any chest pain patient, I would tell you the first thing is a good auscultatory exam. You're going to hopefully hear things that are abnormal if they're present.
Mm-hmm.
So getting a good cardiac exam, listening to the rhythm and the rate, listening for murmurs, listening for rubs. It's important to do it both while they're sitting up as well as laying down because those maneuvers can change the sounds. So you're more likely to hear certain murmurs consistent with hokum or hypertrophic cardiomyopathy in certain positions. And then making sure that you're feeling pulses and checking the cap refill and then looking for the extremity edema.
Yeah.
When I'm specifically thinking about cardiac causes, those are the highlights. And then obviously you want to do a good lung exam as well. I mean, you don't want to only evaluate for the cardiac causes and make sure that you're hearing breath sounds everywhere, that you're not hearing crackles to suggest the patient's wet. Or decreased breath sounds to suggest pneumothorax or anything like that.
Yeah. So kind of at a start, what do you think it is on our differential for this guy?
So it could be something as simple as costochondritis, right? If he's a significant or competitive athlete and doing lots of physical activity, you can absolutely get chest pain from lots of chest wall movement. But again, I'd be really worried about the underlying cardiac causes. So does he have hokum? Does he have an arrhythmia? And that's really where I would be most concerned is an underlying cardiac.
Yeah. So what do we order for this patient?
EKG chest x-ray. And really that's it. I mean, there's not really anything additional to order in pediatrics. The only time I would really consider ordering a troponin would be if the patient had underlying evidence that there was something more going on. So if I see evidence of myocarditis or pericarditis on the EKG, then I would be more inclined to order a troponin.
Okay. So generally we don't need to start there.
Not often. I mean, it's pretty rare that we actually order a troponin to begin with, because it's really a screening tool for myocardial infarction.
Mm-hmm.
And that's not really common in children. So using it for that really is pretty low yield. But in specific situations, you can add that test on later if you have more of a concern for actual myocardial damage.
Okay. So we get a chest x-ray. It looks normal. His heart size is normal. His lungs are normal, and you don't see any fractures. And his EKG is normal as well. Normal sinus rhythm, no obvious abnormalities. So what are you thinking when we have this workup back and it looks normal?
Thinking that because he had chest pain with exercise, he still needs follow up with cardiology, needs to be cleared by cardiology. But without identifying an emergency cause here in the department, that day that it's safe to be discharged home to do that follow up. I would not allow him to return back to sports until he actually was cleared by the cardiologist.
Okay. So like going home with a note that no physical activity.
No significant physical activity. So activities of daily living, sure. He doesn't need to be on bed rest per se, but I would not allow him to engage in any sort of additional physical activity until the cardiologist cleared him.
Would your disposition for this patient change if he had chest pain? Like if he came to the ER and still had chest pain?
Not necessarily, not with a negative workup.
Okay.
Because even though he's got some red flags, meaning that it's happening specifically with exercise, reflux can do that also.
Mm-hmm.
Right. So he's got some red flags that show you he needs further evaluation before he can return to his typical activity. But the presence of pain doesn't necessarily change the disposition.
Yeah. So he goes to cardiology, and we have an amazing cardiology group. They see people really quickly. And so my understanding is they get an echo, they make sure he has a structurally normal heart and it's functioning appropriately. And if that is all good, then they usually can return to activity. Is that correct?
Right.
Okay. Awesome.
Yeah.
All right. Case number 2. This is loosely based on a patient that I saw a few years ago. But she is 5 years old, comes in with chest pain times 1 day. Her triage vital signs show that she is currently febrile, currently tachycardic. Her temp is 102 and her heart rate's in the 160s. She is normotensive, however. She's a little tachypnic, but does not look labored, so she doesn't have any retractions. Her dad says that she's been sick for a while now. She got flu a couple weeks ago. She had flu A. She was treated with a 5-day course of Tamiflu. Her symptoms seemed to be getting better, but of course her cough never really went away. And then 2 or 3 days ago, she seemed to get sick again. Super fatigued, sleeping all day, drinking less, not eating. Fever came back today, and now she has chest pain. When you look at her, she looks sick. But she is awake and she's maintaining appropriately. She'll answer your questions, but she seems to be really fatigued and kind of sleeping a lot. So what other things might you want to know about this patient?
I would ask about history of recurrent respiratory infections or immunodeficiencies. I would want to know about her hydration status. Has she been drinking? Does she look sick because she's dehydrated, or she looks sick because she's got some other underlying process? I'd want to know if she actually had any labored breathing at home. Was she having periods of respiratory distress? And then ask about what her mental status had been at home as well.
Yeah. And parents said she's, sleeping all the time, but when she's awake, she seems appropriate. But they do describe these kind of periods of tachypnea at home, like she seems to be breathing fast quite a lot. So obviously this kid is ringing the sick bell for us when we walk in.
Mm-hmm.
We said she looks sick. Are there any particular exams for this patient, since we're thinking, this is somebody in that sick category, that would help you kind of tease out a diagnosis here with regard to a physical exam?
I'll go right back to the auscultatory exam again. That's really going to be the most important thing for you, is to listen to her lungs, specifically for decreased breath sounds, crackles, and then abnormal heart rhythms. I'm really concerned in this case for like a secondary bacterial pneumonia, like secondary bacterial infection. So a pneumonia or complicated pneumonia, like a pneumonia with an empyema or an effusion. And I'd be worried about early sepsis. I mean, she's febrile, she's tachycardic, she doesn't look well. Her pressure's normal right now, but we in pediatrics all know that pressure is really the last thing to go before they get really, really, really sick. So they tend to hold that blood pressure pretty well, even in early sepsis. And then a good mental status exam is going to be highly important to make sure you really, feel like she's doing okay from a mental status standpoint. Because if she's not, that's going to dramatically change your workup.
Yeah.
And then again, cap refill, pulses, all the things that we've kind of mentioned before.
Yeah. So you mentioned we're thinking kind of pneumonia, empyema. What other things might be on the list for her?
So certainly this could just be a new viral infection and completely unrelated to the previous infection, right? I mean, we see recurrent viral infections in children on a regular basis, especially in the wintertime, where they get
Mhm.
something, they get better, and they get something else. Um, so that's certainly a possibility as well. And then just simple other things like dehydration certainly could be the reason that she's ill appearing. But with her being ill appearing, higher up my list now climbs myocarditis, pericarditis, those kinds of things.
Okay. So what are we going to order for her?
Ding, ding, ding. Chest X-ray EKG. Yeah. Right. So we'll start with that. But I would also be much more likely in this patient to go ahead and place an IV, check screening labs to look for a leukocytosis that might support like a pneumonia, or electrolytes to support dehydration. I'd probably get some urine, looking for other causes of the fever, looking for a urinary tract infection. And the chest X-ray specifically thinking, does she have a pneumonia? Less likely a pneumothorax, just given the fever and that kind of stuff. But is it a pneumonia? Is it a complicated pneumonia? And then also look at the heart size. So is she in heart failure? Um, and then I would give some IV fluids to see if we could resuscitate her, bring that heart rate down a little bit, see if it's related to dehydration. And I would treat her with antipyretics, because
Yeah.
sometimes just treating with antipyretics can dramatically change how they look as well.
Yeah. So on her chest x-ray, she does have a left lower lobe pneumonia. She has a small effusion also. Her heart, however, looks normal. Her white count is 18. She does have a shift. Her CRP is pretty high at 12. She had ketones in her urine, but there's no evidence of a UTI. You gave her fluids, you brought her temperature down, and her temperature is normal now. It's 98.9, but she's still really tachycardic. Her heart rate's in the 160s, and she really doesn't look better. She hasn't bounced back. She's still really fatigued, kind of sleeping in mom's lap, just does not look like she's perked up at all, and still is a little tachypnic, although her breath sounds are normal. So, based on that information, what's now kind of evolving on your differential? Anything you might add as far as diagnostics?
Um, if we hadn't done the EKG already, then I would definitely do that, because that ill appearance again makes me more concerned for myocarditis and pericarditis. I would be more concerned for early sepsis. And then I would wonder if maybe that pleural effusion wasn't a simple pleural effusion. Does the kiddo have an empyema and need something more aggressive in care to help her actually get better? Like, does she need to go to the OR for a VATS or something like that?
Yeah. So she's persistently tachycardic and pretty high, 160s. Why do we worry about that in kids? That's something I really didn't know about before I worked in pediatrics, and we talk
Yeah.
about a lot. So why is that a problem?
So when we refer to persistent tachycardia, we are talking about tachycardia that doesn't respond to our normal interventions to resolve tachycardia. So if you think about the causes of tachycardia, pain can cause tachycardia, fever can cause tachycardia, dehydration. There's a good number of causes of tachycardia that we can actually make an intervention for and change. So when you treat with antipyretics, the tachycardia improves. When you treat with IV fluids for dehydration, same thing, the tachycardia improves. So we do that a lot in the emergency department to try and help us figure out, is this truly persistent tachycardia or not? And then if it is persistent tachycardia, why? Well, when you think of fever and tachycardia, what do people think? Oh, they probably just have a fever. They probably just have a viral illness, right? That's the easy answer. But myocarditis and pericarditis can present as simply as fever and tachycardia. And so there absolutely have been cases that have been missed where kiddo got discharged home where they had fever and they had tachycardia and had no other symptoms, and there was an assumption it was viral. And then the kids comes back later more sick because there was a myocarditis present that we didn't evaluate. So we typically will treat the tachycardia with the interventions that we think might actually resolve the tachycardia. And then if it doesn't resolve, would consider further workup to look for some of those things that can sort of hide,
Yeah.
if you will.
And do you have one of these stories of admitting a kid with persistent tachycardia and they went upstairs and they died?
Not my story. I
Okay.
do know of a story. Yes.
Yeah.
That happened in our facility. Yeah. I mean, it's to me, myocarditis is a little terrifying because it's actually, it can present with such simple symptoms in the sense of what we see every single day. We see fever and tachycardia every single day. So how do you know that every child that you're sending home that has a fever doesn't have myocarditis? You can't do an EKG on every one of them,
Mhm.
right? So you have to have your radar out. You have to have it well programmed to make sure that you're not missing the kiddo that's got early myocarditis, where you could actually potentially make an intervention and change the trajectory of that. of that illness. Yeah, myocarditis is to me the scariest cause in pediatrics in regards to chest pain, because
Yeah.
it's the easiest one to miss.
Yeah, and with regard to tachycardia, I think we say this, and then clinicians kind of hold on to that notion of like I've got to get the heart rate normal before they leave, but that's not really what we mean. Like we would just
Correct.
want to see that you're not discharging somebody with a 180 heart rate. You need to have a kid that comes in with a heart rate in the 160s. You've done some interventions, we hydrated her, we gave her an antipyretic, and then her fever gets better and her heart rate's 135. Like that is an acceptable improvement. Like it doesn't have to be normal.
Correct.
Because I feel like people call us, even from offices sometimes, and they're like, she's persistently tachycardic and her heart rate's 110, and I'm like, is that really, what we need to be worried about?
Right.
But, just showing that you've done this thing, done an intervention. That's the other thing. I feel like a lot of people don't always do an intervention. They just are like, the kid's just all tachycardic. And I'm like, but they're febrile.
Right. Kiddos that get sent from an outside hospital or a clinic for a fever of 105 and a heart rate of 200.
Yeah.
And they're, under the age of a year. And you're like, did you treat and fortunately, sometimes we have the time to say, would you please give them some Motrin or Tylenol before they leave the office? And then by the time they get to us, they're not tachycardic anymore.
Yeah.
So yeah, making that intervention is really important because otherwise you're going to do a whole lot of workups on kiddos that don't actually need it.
And we don't typically, with regard back to myocarditis, we typically are not making like that diagnosis in the ER per se, right? We're suspicious for.
I mean, you can, you should be able to see abnormal. I mean, the majority of myocarditis cases are going to have an abnormal EKG.
Okay.
And then I would follow that up with a troponin and probably a BNP to look at the heart function.
So if you get an EKG on a kid and you're worried about myocarditis, what are we looking for on the EKG specifically?
So sinus tachycardia, I mean, that's part of the reason you're working them up, right? Is that they're persistently tachycardic. And then non-specific ST changes, and you can see various forms of arrhythmias as well.
Okay. And then if we're worried about that and they do get admitted, is this typically like cardiology gets involved? They do an echo?
Yes.
Okay.
Yeah, absolutely. And usually we call them from the department. This is not something we just admit and let cardiology see them the next day. Now, they may determine once we've consulted them that they're stable enough to wait for that. But that would be a phone call that I would make from the emergency department to get them involved.
Yeah. And we didn't talk about this, but what is myocarditis?
Myocarditis is inflammation of the muscle of the heart or the myocardium. And most of the time in children, it's caused from viral infections, but you can see it with bacterial infections, fungal infections, even autoimmune disorders, and then sometimes medications can cause it as well. It can also be idiopathic. So sometimes we don't find a cause for it at all.
But if you're worried, call cardiology and admit this kid. Is that the kind of the take home message
Yeah.
here?
Don't send them home until you've ruled it out.
Yeah, and have it on
Yeah.
your differential for kids that are persistently tachycardic and or
Right.
have chest pain or other complaints. So to switch gears a little bit, what is pericarditis?
Pericarditis is inflammation of the pericardium, which is the sac the sac-like membrane that kind of covers or surrounds the heart, if you will. And so it's just inflammation of a different area of the heart or the cardiovascular system.
Yeah, and I know in adults this tends to be really positional. Is that true in children as well?
Yes, and you can, and that's why I mentioned early on doing an exam, cardiac exam, both sitting up and laying down, because you can hear a rub more clearly when the patient's sitting up or even leaning forward. And in pericarditis, you're often listening for a rub, which is scratchy or squeaky sound that you can hear best over the left sternal border.
Yeah, and I've actually never been successful in hearing one, so I just keep my eyes open if somebody has it. All right. So and on EKGs for pericarditis, what's the hallmark for an EKG on pericarditis?
That's more the sinus tachycardia again, but then diffuse ST segment changes.
Yeah. So it looks like an MI, but it's everywhere instead of
Right.
being localized. So in kids, how do we treat pericarditis? Like I know in adults, we commonly use NSAIDs, colchicine. Those are things that we used a lot in the adult ER. How do we treat it in kids?
The same NSAIDs and colchicine are also the mainstays of treatment. Obviously, if they're sick, they wouldn't go home. I have discharged adolescents home with pericarditis that have no other findings other than chest pain that are concerning after a consultation with cardiology, obviously. But, if they're ill appearing, I would probably bring them in and make sure that they're actually improving before sending them home. And then the other thought process would be trying to determine what the cause of it is, right? So if you can figure out what's causing the pericarditis and it's something that's treatable, you need to treat that as well, not just treat the pericarditis itself.
Okay. All right. So just to circle back around to our 5-year-old with pneumonia, how are we going to treat her pneumonia?
So in this kiddo, I would start IV antibiotics and admit her. I would not be comfortable discharging her home, given the fact that we can just clinically look at her and know that she's ill appearing. She hasn't really improved with the interventions we've already made. So for this little one, I would definitely keep her.
So let's kind of change that scenario and say, hey, we found a pneumonia, but she responded to the Tylenol. She looks great. She has perked up and she's drinking and she feels better and her respiratory rate has gotten better. Would you consider sending that home?
So if she has a chest X-ray that just shows a pneumonia and doesn't have what we would call a complicated pneumonia, meaning no pleural effusion, no evidence of an empyema, not a multifocal pneumonia, just a simple lobar pneumonia, and she perked up, absolutely. We treat lots of pneumonia as an outpatient in children that are otherwise well appearing.
Okay, awesome. We're going to move on to case number 3. This is a 9-year-old female, and she has had 1 day of chest pain. It started while she was eating lunch today, and it's been pretty persistent since. Mom gave her Motrin when she got home from school, and it has not helped. She has no past medical history, recent illnesses or cough, no trauma. Her vital signs are normal. Her physical exam looks 100% normal, including a skin exam on her chest. No reproducible chest pain when you palpate her chest. Any other questions or thoughts on this patient as we move forward?
I'd kind of ask the same questions I've asked the other patients because, the role in the ER is to rule out the emergencies. So we're going to dig into, did they really have any cardiac symptoms or any respiratory symptoms that are concerning? But given what you're presenting, I have a pretty low suspicion that we're going to find anything that's concerning from an emergency standpoint on this patient today.
Yeah, no big red flags.
Right.
All right. So on this one, what would you think about for your differential?
So I'd lean more towards either musculoskeletal causes or GI causes.
Yeah.
So our 2 most common, I think, are really reflux and then costochondritis being the 2 most common causes in the peds emergency department.
And we're going to order a chest x-ray and an EKG because we're ordering that on our kids with chest pain.
Yep.
She has pain still. Would you consider giving her something while we're waiting on those tests to come back?
So I like to trial a GI cocktail for the kiddos that are still having pain because it can be a really good way to assess, did that make a difference or not? If they have esophagitis or gastritis and you give a GI cocktail or some Malox and they get better, there you go. That's your answer. You literally just solved the puzzle in the sense of what's causing the pain because you treated for, you numbed it basically. And if pain goes away, there you go. That's your source.
Yeah.
If they don't have active pain in the emergency department, that makes it really hard. So if they were refluxing before but aren't refluxing when they arrive, that's a little bit harder to use that tool with.
Yeah. And I use Carafate, but same idea.
Right.
We all have the tools that we like in our little toolbox. So her chest x-ray or EKG look normal. What's our disposition for this patient?
This patient I would definitely allow to go home. I would educate that we didn't find any emergency causes of the chest pain in the emergency department, which is a great sign, but that she may need further evaluation if her symptoms persist, and would recommend following up with the pediatrician. If the GI cocktail worked, I would consider sending her home on some famotidine. Sometimes I send them home on famotidine anyway, if I just get a suspicion that this may be reflux related, even if they didn't have pain in the emergency department. But just reassuring them that we didn't find anything worrisome and that the outpatient follow-up is important would be the mainstays.
Yeah. And if this was more chest wall pain or costochondritis, because she's had a cough or she's been sick recently, how would you treat that patient? Like, what would you send them home with medication-wise?
Then I usually do NSAIDs for about a week, kind of around the clock, because they help decrease the inflammatory process as well as help with the pain.
Yeah. Is there a role for steroids for these patients?
And for what?
For the pain, for the chest pain. I just see this a ton in practice. So
I have never heard of steroids for chest pain ever. I don't know if that's a common adult practice, but it didn't even cross my mind.
Okay. That kind of covers our benign causes of chest pain, probably the most common ones we see. So let's move on to case number 4. This is a 16-year-old male with acute onset left-sided chest pain. It began while he was at school today, and it's associated with some mild shortness of breath that he reports, although he doesn't look labored. He looks very comfortable. He's been otherwise well, no recent illnesses, and his vital signs are normal. Where are we headed with this guy?
So again, we do the typical workup, right? Kind of a reflex to sort of order it before they even come in. I'd be less concerned about sort of the infectious causes in even myocarditis or pericarditis, just because he's not ill appearing. I might think kind of more musculoskeletal and would consider it pneumothorax. I would want to kind of see, is he tall? Is he thin? Because that's certainly a risk factor for that kind of thing. If it was just kind of acute onset. But certainly, I think myocarditis and pericarditis are still on your list because he has pain without a whole lot of other symptoms.
Yeah. Well, he indeed has a pneumothorax. It's about 20% on the left
Okay.
side. Very classic in this age group. This is almost exactly what I saw out at Easton, ordered a troponin on, by the way. So what do we do next when we have a kid that comes in with a pneumo?
So it really kind of depends on how the kiddo looks. If the kid is otherwise stable and not in distress, that's going to change your management. So if they're ill appearing, if they're in distress, you're going to focus on airway stabilization first. Sometimes they're hypoxic, so you would want to do supplemental oxygen to treat that hypoxemia. And then a lot of them have pain, and the pain's causing them to splint and not breathe as deeply as they would, and causing them to have more distress. So treating that pain is important as well. The good thing to know about spontaneous pneumothoraces is that they're rarely life-threatening. And the majority of them are often mild, and they really only tend to have mild pain and mild symptoms in the sense of shortness of breath, kind of only with exertion. Some of these kiddos do end up with chest tubes, and I think that's kind of dependent on the institution, dependent upon the surgery group and the presentation in regards to the size of the pneumothorax. So certainly in a kiddo with a smaller pneumothorax, you honestly don't need to make an intervention at all unless you're just treating pain, especially obviously if they're not in distress. In a bigger pneumothorax, usually the surgeons ask me, what do they look like? And that helps them sort of determine, do they do a pigtail catheter? Do they do just a traditional chest tube? Or do they just admit for observation if they have a decent sized pneumothorax?
Yeah. And if they do put a tube in, do they normally end up to this VATS procedure where they go in and they try to prevent it from happening, or what does that look like? Do you know?
So I've only seen them do that in kiddos that have recurrent pneumothoraces. I've never seen that happen in a kiddo that's just a one-time spontaneous pneumothorax. And yeah, I've only ever seen them go in there and try to tack things down if they have recurrence.
Okay, awesome. All right, and our last case is going to be a 15-year-old male who has 1 day of substernal chest pain. He has been well, but reports he does have a mild cough that began after the chest pain. He doesn't have any dyspnea right now by report. He's had no recent illnesses or fever, no trauma, no medications tried at home before he came in, and his physical exam looks good. So walk us through this guy.
So again, I would do the same workup. I'd ask the same questions, do the same workup. If his physical exam's reassuring, again, my radar is telling me that the likelihood that this is probably benign. But I would want to see what the test results are because I've been fooled before, kids that look great and you go, oh, wow, look at that.
Mm-hmm. Yeah, well, we get our chest X right back, and he actually has a Pneumomediastinum.
And you told me he only had mild cough. So that's surprising to me because really, we see pneumomediastinums, but I have seen them really more in asthmatics than anybody else. And usually not just from mild cough. So I'd sort of be curious about how much this child's actually coughing. We know that with a lot of our asthmatics, they often, let me put it this way. Many asthmatics have under-recognized symptoms. So I'm wondering if this cough that they're calling mild is really more significant by our definitions.
Yeah.
Obviously GI causes are possible, but really only in the setting of like prior procedural things. So a recent scope, that kind of thing. But almost always, I feel like when we see this in kids, it's an asthmatic.
Yeah, and it's
Or
unusual. I think I've only seen this once.
Yeah.
I was reading that vaping has contributed to pneumomediastinum. Have you seen that?
I hadn't thought about that. I have not seen that. I feel like I see more pneumothoraces than I do pneumomediastinums with the vaping.
I feel like if you don't work in pediatrics, this is a diagnosis that scares people and concerns them. How do we normally take care of this patient?
So we actually, the majority of those resolve on their own, but obviously you need to treat the underlying cause. So if it's an asthma exacerbation, they're going to continue to worsen or continue to develop continued symptoms if their asthma exacerbation doesn't get treated. But the actual pneumomediastinum itself, we let resolve on its own.
And do we normally admit these kids or do they go home?
Again, that kind of depends on how ill they are. If they're sick enough to be admitted because they have a bad asthma exacerbation, sure. But if they're well appearing and, we feel like we can treat the source and decrease the likelihood of it happening again by treating the underlying cause, then some of these kids can be discharged home.
Yeah, I was really surprised the first time I saw one of those discharged. So, okay, well, I thought we would wrap up today and just briefly talk about ACS and PE. Now, in kids, these diagnoses are not at the top of our list like they are in adults. These are rare in kids, but not impossible. So we have to kind of think about them and not forget about them completely. So, in the pediatric population, are there factors that do, and we talked about this a little bit earlier, but things that might ring some bells for you to look more at like an MI cause?
So really, family history is probably going to be the biggest thing. There aren't. I'll be honest. In the 20 years I've been practicing pediatric emergency medicine, I have never seen a STEMI.
Yeah,
Never.
I've only heard
Never
one
seen.
story, Shelley's story.
Yeah, it's so rare that yes, we're doing the EKG partly to make sure that there's not a STEMI, but it's so rare that it really doesn't climb high on my list ever.
Yeah.
If I ended up with an abnormal EKG, obviously, in fact, I did end up with a patient that had EKG that read STEMI, and I looked at it and kind of went, oh my goodness. And I ran over to the adult side and I was like, is this a real STEMI? Is this a real STEMI? Because, I don't know. I've never treated one, right? And they were like, no, that's not real. It's blah, blah. And I was like, okay, all right, good. So that's how much experience we have, is that I kind of freaked out a little bit and went running to my adult colleagues who do it all the time. It's just so unusual that it's never going to be high on our list, even with a family history.
I do wonder sometimes, like with our population getting sicker and younger people having high cholesterol and high blood pressure and weighing 400 pounds and all the things that we're seeing in our population, like by the time, even while we're practicing before we retire, are we going to have to start to get more concerned about that? I mean, obviously we haven't seen it yet, but.
And that is quite possible. I mean, we already are seeing more adult type diseases than we saw years ago. The number of type 2 diabetic patients that we have that are under, the age of 18 or the age of 21, depending on what your institution treats, is much greater than when I was training. So it's, the significant obesity that we're seeing in children, I absolutely think we're going to start seeing more adult-like diseases in children.
And another thing I thought about just from adult world is cocaine use. I feel like we're not seeing a lot of cocaine use in general anymore these days. Not that it's impossible, but always a possibility, I would think, for an MI potentially.
Right. Yeah. And not in our population. I think that varies by region. Mm-hmm. And certainly there are different drugs of choice in different areas depending on access to things. And I just don't think we see a lot of that where we are.
Yeah. All right. In PE, what red flags would you look for in a kid specifically if you're kind of thinking PE?
So the symptoms are going to be the same in a PE in a child as they are in adults. So you're going to look for tachypnea is really the biggest thing, tachypnea and chest pain. PEs are also rare in children, but if they have other risk factors, so like an adolescent female who's taking OCPs, the typical stories of being still for a prolonged period of time, like in a car ride or on a plane, that kind of stuff. Those are the things we're going to sort of ask if they have the tachypnea and the chest pain. Looking for unilateral leg edema, certainly as well.
I've seen 2 PEs in the children's ER, and they were both post-COVID and thought to be related to COVID. I haven't seen one since. So,
yeah.
How often would you say you run into one?
Certainly more often than an MI.
Yeah.
But I don't know, once, maybe twice a year.
Yeah.
In the department, I would say, not even for each of the providers there, but I think we probably see 1 or 2 out of our entire population. A year.
And they're probably on the HEMONC service.
Yeah.
Okay. Well, of course, there are tons of causes for chest pain. You could have a chest mass. This could be musculoskeletal. It could be an asthma exacerbation. It could be Kawasaki's disease, congenital heart disease, SVT. There's a million things we could list here. But I hope today was helpful just to kind of raise your awareness that chest pain in children does not always need to be the same workup that you see in adults. It is safe to start just with an EKG and a chest x-ray and then expand that testing as needed based on how your patient is presenting and how they look on exam. But also be aware that despite many benign causes of chest pain in kids, there are also really dangerous things that cause chest pain in kids. So keeping some of those things like myocarditis in particular on your differential. And so keeping your antennas up for some of the more concerning causes of chest pain in kids. Of course, when in doubt, as an APP, talk to your attending, call a trusted resource, call a peds cardiology. Lots of resources out there for you if you have concerns. And if you don't feel comfortable sending somebody home, don't, right? We have resources. You can put them in the hospital and complete that workup. So before we close today, I wanted to thank you again, Sarah, for joining me today. It's been awesome to have you on the podcast. Thank you for your time, because I know it's in short supply. Anything else you want to add before we wrap it up?
No, other than just say thank you for the opportunity. It was my pleasure speaking with you all today. And I hope that by reviewing some cases of chest pain in kids, that we've sort of given you some tools that make it easier for you to do good workups in your pediatric patients.
Awesome. All right. Thanks so much.
Thank you.
Thanks for being here today with us on PEM Chat to talk to Dr. Sterner about how we approach a chest pain workup in the pediatric population. Now, join us next month when I'm actually going to have two guests on for a two-part series. We are going to be joined by two pediatric clinical pharmacists, Maggie and Morgan, and they are fantastic. And we're going to talk about antibiotics, and we're also going to talk about common medications we use in the emergency department. So I look forward to having you back then. We'll see you next month. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.